All right, so my name's Ken Milne, and I'm going to be giving 3 lectures, 2 today and 1 tomorrow. I'm going to be doing the roundup tonight with Peter, and Peter and I are going to be covering today's lectures and trying to consolidate that information so you're like, yes, I feel so excited about this exam. I have not felt better, or something close to that. The first lecture is going to be on hematology and a little bit about HIV. So this is one of my favorite lectures to give because it's about bleeding. And I take residents where I train and train them to not panic, because that's a core concept of emergency medicine. Don't panic. All bleeding stops eventually. Nobody bleeds forever. This too shall pass. They'll run out eventually. You'll go home. So we're going to cover, some basic stuff just about blood products and things, and then we'll move into some specific disease states and some of the medications that we use to make the blood a bit thinner and also to stop bleeding. And then right at the end, we will cover some things on HIV. So to begin with, we've got some really easy stuff on packed red blood cells, some basic facts on it. And the basic fact that starts with, it lasts 5 or 6 weeks. And it's packed, so it's concentrated, so it can carry more oxygen. It can bump up your hemoglobin by about 1 to 1.5 for every unit you give. Now, if you want to figure out how much blood you have, you take the average person, 70 kilograms, and by the way, I can translate, that's 154 pounds for the people not doing metric. I mean, the only thing you guys do in grams is cocaine. So I'm clearly not the average. I'm a little above average, 70 kilograms. But you've got about 70 mils per kilogram. And so 70 times 70, you have about 5 liters of blood. So if they ask you on the exam, how much blood? 5 liters. When we're giving packed red blood cells, we're not giving it for the platelets and the clotting factors because it really doesn't have any. And that highlighted part in the back is pretty basic stuff. You know what the universal donors are, and you know what the universal recipients are for blood products. Some more details about packed red blood cells. The reason we give it is because it's more concentrated and we can give less volume. Because if you give a great volume of red blood cells that don't have platelets and then don't have coagulation factors, you can get into trouble. Also, they put in citrate in there to prevent clotting, and that can have some problems with your electrolytes, and specifically hyper and hypokalemia and hypocalcemia. So your potassium can go too high, too low, and your calcium can go too low. And your heart's dependent on calcium for the old pumping factor, so you can get into QT prolongation and some arrhythmias if your calcium goes too long. You dilute it with normal saline, and I'm not going to get into are we giving them saline and Ringer's lactate debate. That debate's been going on forever. But if you're giving packed red blood cells, it has to be normal saline. And then calcium in the Ringers can cause micro clots, and so they put these filters on these transfusion devices. That's something that the nursing staff will do, but it's best for us to recognize that if you notice your patient's crashing and it's showering and it's going into acute renal failure, they're getting into neural problems, they're going into ARDS, it may be related to somebody forgot to put that filter on the Ringer's lactate. Now, massive blood transfusion. This is becoming more and more important. We get most of the information from the military that have had to deal with massive transfusions. The specific definition is replacing your total blood volume within 24 hours. I'm going to add something to that slide. Or 50% of your blood volume in 4 hours. Okay, that was left off there. So complete blood volume, 5 liters if you're a 70 kilogram person, 5 liters in 24 hours, or half that in the first 4 hours. Anybody here work at a critical access hospital? Okay, the massive transfusion protocol at your shop will be both units of O negative. The submassive transfusion is 1. All right? And that's just to make you remember that if you replace your entire blood volume within 24 hours, it's considered massive transfusion protocol, or 50% in 4 hours. And now we've moved to this fixed ratio. The trial that did that was called the PROPER trial, and that's how I remember. They want the proper ratio to be 1 to 1 to 1. Fresh frozen plasma platelets and RBCs, 1 to 1 to 1. Because if you're giving packed red blood cells, you're not getting clotting factors, right? And so they want a fixed ratio. You're not getting any platelets, so they want platelets in there too. So a 1 to 1 to 1 ratio. One of the problems with giving a massive transfusion is, it's cold, right? Because the body temperature, of course, is warmer than the room temperature, unless, of course, you stand at that door over there. That's called the polar vortex right there, or the Vegas vortex. You could sit there and paraglide right at that door with that. Did you notice that? Anyways, so it's going to be cooler, right? So you got to put it on the blood warmer. You got to watch for those micro aggregates, like I talked, showering the vascular beds. And so those little filters are important. And citric toxicity, that's there down at the bottom. It can get buried there in your memory. But citric toxicity, to prevent clotting of the red blood cells, you can get into trouble lowering your calcium. And if your calcium's low, your heart's not pumping, your QT's getting long, and you can get into an arrhythmia. So watch for that. Now, there are a number of different types of reactions that you can get with blood products. And with packed red blood cells, the acute hemolytic transfusion reaction is probably a really important one. It's acute, and it's destroying your red blood cells. And this is the ABO incompatibility thing, giving the wrong blood type to the wrong person. And the host will rapidly respond and destroy those red blood cells, and then that'll shower your vascular bed, and you're in for badness. But look at the numbers down at the bottom there. There's only about 20 deaths a year after about 15 million transfusions. It's almost like 1 in a million chance that you will get an acute hemolytic transfusion reaction. So you may not have seen it, but you need to know about it. And do you know why there's only 1 in a million? Have you seen nurses give blood transfusions? They are like on a nuclear submarine. They have to go and break open some secret code, pull it out. They have to stand side by side, read it out, then barcode stuff, and then they have 2 keys and they insert them, and on the count of 3, 1, transfuse. Right? You've seen that process, right? And there's a reason for that. It's deadly. And so it's really safe for an acute hemolytic transfusion reaction process. So what do? Stop the transfusion. If you suspect this, if the person is looking very unwell, febrile, stop it. Stop the transfusion, hydrate it to try to flush all that badness out, and treat them symptomatically, and then you send off the labs to get the Coombs test and feel great shame. If it comes back saying you gave the wrong blood. It may not. Because you could have a febrile non-hemolytic transfusion reaction. So the patient's febrile, but it's not due to ABO incompatibility. And this is the most common. So the acute hemolytic reaction is deadly. This is the most common. And this is how they try to trip you up on the exam. They'll say, oh, what's the most deadly? But this is the one you're more likely to see. The patient's febrile, but they're not causing hemolysis. It's not destroying the red blood cells. They get fever and chills, and there's a spectrum, so it may be difficult to tell the difference between a febrile and an acute hemolytic transfusion reaction. But again, you stop the reaction and then do the investigations and check to see that Coombs test to see if it happened. Now, acute allergic reactions, your emergency physicians, I don't need to explain those. They look like allergic reactions. They have hives. They have itchiness. They are hypotensive. And it's usually due to the plasma proteins within it. It's not the ABO incompatibility. That's the acute hemolytic reaction where they're going to destroy the red blood cells. But these proteins that come in the packed red blood cells can expose you to an allergen. And it's not dose dependent. And that's key for these reactions. It can be, we just started the transfusion, doctor, and they're already looking bad. Or it can be at the end of a transfusion. It's just like, the first time you get stung by a bee, it can be the last time. Or if you're allergic to shrimp, but you don't know because you've never had shrimp before, it could feed you for a lifetime. Right? So it's not dose dependent. It depends on being exposed and having that vigorous immune response and taking a mast cell dump. That's the allergic reaction. Then you have delayed hemolytic reactions. That's another type of transfusion-related reactions. So we've had our acute hemolytic, our febrile, now allergic, and now a delayed hemolytic reaction. And that's just some of the proteins don't kick in and don't cause the reaction. It's a delayed reaction by about a week. Similar but milder presentation. And then I've mentioned some of these electrolyte abnormalities. Hyper-K, of course, if you're transfusing a lot of blood, red blood cells, and you're transfusing it fast, those red blood cells lyse open and spill out their potassium, right? Because most potassium is intracellular. All right, the low calcium is due to the citrate causing chelation, or the citrate prevents chelation. Anyways, it gets prolonged QT, but you can also get hypokalemia, and this is from the citrate, and it goes through a metabolic process, but at the end of the day, you can be hyperkalemic or hypokalemic, and then the hypothermia and fluid overload. Infection. This used to be a big deal. If like you're writing this for the first, second, or third time, that means you're 10, 20, 30 years into it. Do you remember the 80s? I mean, some of you may not remember the 60s, but do you remember the 80s? Right? It was paranoia and panic because of the blood products and because of AIDS and because of the hemophilias that were getting these blood products and transfusions and stuff. It was really scary, and people were really, really concerned about catching something from a transfusion. I don't get that as much anymore when I'm doing transfusions. Patients aren't as concerned because the blood system is much, much better than it was back in the mid to early 80s and even up to the end of the 1980s. But if they say, what is the most common contamination? It's bacteria, skin bacteria, right? It's a contaminant. It's a skin bacteria. That's the most common thing, but it's not pathologic and it doesn't cause infection. But if they look for infection, hepatitis B, 1 in hundreds of thousands. Hep C and HIV, 1 in millions chance of getting a transfusion infection. And then West Nile and Yakov-Creutzfeldt, we don't even know it's that rare. All right, that's it for red blood cells. We're going to move on to the platelets. And as opposed to the red blood cells, which last 5 to 6 weeks, up to 40 days, 42 days, these last 5 or 6 days. It's sort of the fresh frozen sort of thing. So 5 days of storage life. Doesn't last very long. 1 unit of platelet will bump you 10,000, and you know that normal is 150,000 to 450,000. So each unit's going to bump you about 10 or 10,000. Now we try to do them in ABO compatibility so that people get the same blood type when they're giving platelets as well as red blood cells to prevent these reactions. And you know that the role of platelets is to clot, to agglutinate, right? To clot. So we don't need to go through that. But when do you transfuse? And the answer is it all depends. If you get less than 50,000, you're one of those people that we say, I bet you bruise like a peach, right? You know, and then if you get below 30,000 platelets, those are the people that go, hey, is that a coffee table? And they're already bruising right on their shin. They didn't even make contact. And then if you get less than 10,000, we're getting really worried about intracranial hemorrhage, spontaneous bleeds in bad places. That's just the general, so 50,000, 30,000, 10,000. And we like to get people up above 50,000 to keep them safe. And when it comes to platelet disorders, it's nice to dichotomize them into palpable purpura, so purpura, palpable purpura, and non-palpable purpura. The non-palpable purpura, just think, my platelets aren't around. I don't have enough of them or they're not working. If you have palpable purpura, think vasculitis. Okay? Think vasculitis. If it's non-palpable purpura, when you feel that bruise, look at it and feel it. If it's non-palpable, you're like, hey, I don't think they've got enough platelets, or the ones they have aren't functioning very well. And there's a number of different drugs that can prevent your platelets from working well or functioning well. Some of you may be on those right now. Some might be taking an aspirin a day. I'm taking some ibuprofen right now for my knee, so NSAIDs can interfere with the function of the platelets, and we've got another bunch of drugs listed there that can interfere with platelet function. But how about if you don't have enough platelets? There's just 4 major categories of not having enough platelets. The first is you're not making enough. Aplastic anemia. And if you want to watch a great Netflix show, and I'm not advertising obviously for Netflix, but I watched Chernobyl, because when I got down here early last night and I watched a couple episodes of Chernobyl and the aplastic anemia, it's really cool. So radiation, here's a safety tip. Don't go into a nuclear reactor that's had a meltdown. It could cause aplastic anemia, all right? So there's a number of drugs and viruses and infections that can cause decreased platelet production. You can increase platelet destruction, and there's a whole bunch of three-letter names, and we're going to go through those today and a little bit on the peds tomorrow. And then your spleen can hold a whole bunch as a filter and sequester and store your platelets, and then you can lose it either through bleeding or people that are on chronic dialysis, they're filtering their platelets out through the dialysis machine. So that's it. You don't have enough because you're not making enough. You don't have enough because you're destroying the ones you have. You're hiding them somewhere, like in your spleen, and there's a number of different things that can cause your spleen to sequester them, and then you're losing them either through blood loss or dialysis. So we'll go through that first one of those three-letter conditions, ITP. It can be immune or idiopathic thrombocytopenia purpura. So the I, the immune destruction of the platelets, it means we don't have another reason for it happening. So we call it idiopathic, meaning the idiots don't know the pathology. I haven't figured it out, and neither has anybody else. So they have low platelets for no other cause. Now, there's a pediatric version and a grown-up version. The pediatric version is mild, and it usually resolves on its own, doesn't often require treatment, and they come in because they have low platelets. Their purpura are non-palpable. So they come in with petechiae and purpura that are non-palpable. And you go, their platelets aren't working or they don't have enough. In this case, they don't have enough. They're being destroyed. My father-in-law is a pediatrician. He used to always say, if you're an optimist, it's ITP, and if you're a pessimist for these children, it's leukemia, because they're coming in without platelets. And they generally do well. The adult version, like most immune things, more common in women, slower on onset, and you often have to take some intervention. So here are the treatment thresholds. If you've got a platelet count between 20 and 30,000, you should be giving platelets. If they're actively bleeding, but they're sitting at 40,000, they're going to be losing more and they're bleeding, that's when you give them platelets. Okay, so we have different thresholds. If it's less than 10,000, we're automatically giving it. But if they're between 20 and 30,000, we're giving it because they've got this immune response that's going to continue to chew those platelets up and drop that count even further. And if they're in that 30 to 50,000, we're thinking, okay, but they're bleeding, even more important to give them platelets. So we suppress the immune system by giving steroids. And there's this other tricky thing that you can do, and I mean tricky not as in it's complicated, but tricky to think about because it's tricking the body. You give high-dose RhoGAM to Rh-positive people with ITP. I know, blank faces. I don't know a lot about obstetrics. The only time I deliver is when they're pushing right at the door. They're crowning out of the back of the cab, right? And I always have to ask, are they Rh negative so I can give them RhoGAM? But this is an ITP, and if they are Rh positive, you give them RhoGAM because it's a bait and switch. The body's immune system is destroying their platelets. So what you do is you trick the body and say, hey, forget about those platelets. How about these yummy coated, RhoGAM-coated Rh-positive red blood cells? Why don't you go over their immune system and destroy those for a while and let the platelets rebound? And that's the bait and switch. You can always pour some more red blood cells in. So they give RhoGAM to Rh-positive patients if they've got ITP, as opposed to just steroids. It works better, but it's also more expensive. All right, so now we're going to go through some blood testing. So we've talked about the red blood cells and the packed red blood cells and things about that. We've talked about platelets. Now we're going to talk about some of the testing that's done. I don't order a lot of platelet tests, all right? The things I'm more familiar with, you're probably more familiar with, and that we usually get are things like PT and PTT, INR and PTT. So prothrombin time, INR. It measures the extrinsic pathway, the tissue factor, the extrinsic pathway. And things that interfere with the extrinsic pathway are things like Coumadin and warfarin. If they have liver disease, some kind of malnutrition because they're not getting enough vitamin K, And so people with substance abuse disorders, alcohol substance abuse disorders, eating disorders, things like that, they can all affect the clotting cascade from the extrinsic pathway, and that's measuring the INR. Now the PTT is the intrinsic pathway. That's where heparin fits in. That's how I remember it. That's where you get your von Willebrands and your hemophilias over on that side. And the reason I'm saying sides is because, unfortunately, you're going to have to memorize this. There, you got it? Here, I'll do it again. Okay, we're good? Yeah, no more? No, we're good? Okay. And then platelet disorders, or platelet counts. Remember I said there's 4 things why you'll have low platelets. Either you're not producing enough, so bone marrow issues, you're destroying the ones you have, you're hiding them or sequestering them in your spleen, or you're losing them, and you're losing them externally through bleeding or hemodialysis. So here's that clotting cascade thing, and yeah, I'm sorry, you're just going to have to know this, because this helps with figuring out the conditions and how to treat them. So on the right-hand side, you have the yellow extrinsic pathway. That's where you're going to get your INR, your PT, okay? On the left, you have the blue, and that's the intrinsic pathway. That's where heparin and the hemophilias fit in. And then that final common pathway is the X-men, right in the middle, the X, factor 10, right there before it drops down into that pink area. And if you can keep this organized that way, you'll be able to approach the various things and know how to treat them. So we might as well start with the hard one, DIC, right? Disseminated intravascular coagulopathy. It's a consumptive coagulopathy. It sucks up your clotting factors. It sucks up your platelets. And so you bleed, but also because of all the breakdown products that you have, you can also clot. And that's why it's very difficult to manage DIC. You see it in sepsis, specifically meningitis, head injuries, and retained products of conception. Those are the 3 big ones. And what you'll see is, if you're consuming all your clotting factors, you're more likely to bleed, but you can also clot. You can get a prolonged INR because it's an extrinsic pathway. It's a tissue factor. It's on that right-hand side. It's in the yellow. All right? And I'm just trying to make you remember that so you can get it for the exam. But however you figure that out, it's on the yellow side. It's the extrinsic pathway. It's the INR. DIC predominantly affects that. It consumes all the platelets because it's consumptive. You'll get low fibrinogen level because it's consumptive. But then you'll get sky-high D-dimer levels because you get degradation products. And if you think about what's going on, you'll be able to anticipate the lab test they may give you in one of the STEM questions for the exam. How do you treat it? Treat the underlying thing. So if it's meningitis, you're going to give appropriate antibiotics if it's bacterial. If it's retained products of conception, you're going to get on the horn and get someone from OB-GYN to come in and remove the retained products of conception, things like that. Fresh frozen plasma, PCC, you may give platelets. The last thing is sometimes they have to give low-dose heparin because they're starting to clot. Oh, they're bleeding and they're clotting. Why don't you make it hard for me? Right? And that's why it's got a high mortality rate. All right, from DIC to TTP, it's similar to DIC. You get a severe decrease in platelets. It's right there in the name, thrombocytopenia. But jump down all the way to treatment, you don't give these people platelets. It can make things worse. Even though they have low platelets, thrombocytopenia in TTP, the T is for thrombotic, you can make the thrombosis worse by giving them platelets. And that's a key concept and a really easy question to ask you guys on an exam and mess you up. And say, oh, look, they have low platelets. It's TTP. Give them platelets is one of the answers. And you're like, oh, my God, I'm so into this exam. That sounds right. You know, you can see that happening. All right, they get severe microangiopathic hemolytic anemia, so they're also anemic. Neurodeficits are usually the side effects or the symptoms that they present with. It can also get renal, but renal's more with HUS, and I'll talk about that in the PEDS lecture some more, and they can be febrile. The causes can be idiopathic, it can be infectious, it can be drug-induced. You give them steroids for this, for the immune system, and you do plasmapheresis, and you give fresh frozen plasma, but you don't give platelets. Even if you give them platelets for TTP, that can make them worse. And there's a table to help you sort of organize your thoughts around TTP and DIC. Like I said, HUS we'll cover tomorrow. Again, HUS children, the other one can hit any age, but usually adults. And the prognosis goes from the good to bad to ugly, from HUS to TTP to DIC. All right, heparin. This acts on the blue side of that cascade, the intrinsic pathway. And remember, it doesn't cross the placenta. You know that because if some woman who comes in and pregnant and you diagnose them with DVT and PE, what do we give them? Heparin or low molecular weight heparin. Even low molecular weight heparin is a huge molecule when it comes to the placenta and will not cross the placenta-blood barrier. And so that's the safe drug. That's the appropriate drug to give someone with VTE who's pregnant. Complications, yeah, it can lower your platelets and cause bleeding, and you reverse it with protamine. That's your antidote, protamine. Low molecular weight heparin, it's the same as regular heparin, it's just easier to dose, and you don't have to follow a PTT on them, right? Same as the regular heparin, just easier to dose once or twice a day, and you don't have to titrate it based on their PTT. Warfarin. This slide, like, if this course continues, eventually I won't have this slide. If any of you teach residents, they go, what's warfarin? All they know is DOACs now, right? I'm like telling them with a story about out west and the cow silage and how it caused bleeding and all this stuff. Where did warfarin come from? How did they get the name? I mean, these are trivia questions I've been using for decades. It's going to fall out of favor. I'm not going to be able to use it anymore. They won't the residents don't get my jokes anymore on shift, so now that I give them a USB key with 5 movies from the 1980s at the start of the rotation, and I expect them to watch them by the end of the rotation, I flip the classroom, but I have one shift with them first to figure out where their educational needs are. So if I go, what's the answer for this? Anyone Bueller? And they look at me like, you're weird, Dr. Milne. I go, okay, Ferris Bueller's Day Off is going on that, right? And so I have core movies that I put on this USB key to give them. Same thing's happening with warfarin. They don't know how to manage. I mean, we are warfarin experts here, right? We know how to manage these people. 2, 7, 9, 10, monitor their INR. Overcoagulation does not cause bleeding. Juggling chainsaws cause bleeding, but you don't spontaneously hemorrhage because your INR is 8. Even if a primary care physician calls at 2 o'clock in the morning panicking because they got a critical lab value and they woke the patient up to have them come in for their INR of 8. Are you bleeding? No, but I almost fell down the stairs when I got the call, right? So it doesn't cause bleeding, but if you bleed, it can be really bad. I was going to put a list of all the drugs that could cause or interfere with Coumadin, but that would take the rest of my slides. I could put one drug. Is there one drug that doesn't interfere? Every time I look up on my little auxiliary brain, almost everything seems to interfere with warfarin. All right, so what do you do if someone comes in with the INR of 8? Like, what's the protocol? Well, CHEST had a great guideline in 2012 on how to manage it. First of all, if their INR is really high, if you just stop Coumadin, it's going to take 2 to 3 days for that to start coming down, right? It doesn't come down immediately. Now, there's sort of a couple of different scenarios, so it all depends. If someone comes in with a nosebleed and an INR of 8, are you going to reverse them? And the answer is it all depends. If I walk into the room and hear click, 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 and I reverse them, because of that mechanical heart valve, what have I guaranteed happening? A stroke, and I could have just done, well, you're not bleeding now, right? So it depends on where they're bleeding and why they're on the Coumadin in the first place. And so if they've got a mechanical heart valve, that's high risk for stroking out if you reverse them, right? If it's a bleed you can get to, like plugging an anterior nosebleed of the Kesselbach plexus. But the opposite side of things is if they come in and they've got a head bleed, and their INR is 8, and I'm reversing them regardless, right? They're bleeding GI, I'm reversing them, but you go, so why are you on the warfarin in the first place? And they go, well, 20 years ago back in college, I broke my leg, I was laid up for a couple of weeks, I had a cast on, and I got a clot in my leg, and the doctor said I needed to be on this. I'm like, that was 20 years ago, right? And so they may not even need to be on it. So it's completely safe to reverse them, especially if they have a life-threatening condition. Always choose life, right? And so we have different ways of doing it. You can give IV vitamin K, but that's going to take hours to a day, 12 to 24 hours to start normalizing that, even with IV vitamin K. And so now we have the PCCs, and they will correct like that. I've seen people with really high INRs come in, and we give them the PCC. We give them those 4 factors, and you check their INR in 30 minutes to an hour, and it's normal. Like, it's really, really works well. Now, whether or not it changes their clinical outcome, if they're regardless, if they do die, they will die with an INR of 1.1. Okay? So whether or not it has a clinically relevant, it's a disease-oriented or a lab-oriented outcome. It may not be a patient-oriented outcome, normalizing it, but certainly if they're bleeding and they're on warfarin and you need to reverse them, PCC is the way to go. That's the recommendation. I would just warn you that if they have a mechanical heart valve, to think about why are they anticoagulating and can we stop the bleeding with just direct pressure. And then we have the direct thrombin inhibitors. Well, I shouldn't say inhibitors. We have one, dabigatran, right? And dabigatran is the prothrombin complex or prothrombin inhibitor, and it's been on the market for a number of years now. They have a reversal agent for it now. Again, whether that reversal agent causes a patient-oriented benefit, I can't really speak to that because they had no comparison group in that study where they showed that they could reverse dabigatran. The factor Xa inhibitors, I can say that at least because you know there's more than one and there's a list of a few of them. They all go through different renal excretions and things like that. I don't know if it's that important. What's really important about these drugs is know that they peak within 2 to 3 hours, right? They get up quickly, right? They get up quickly. So you can dry start someone on rivaroxaban for a DVT. You don't have to bridge them with heparin or low molecular weight heparin. They get up pretty quick, right? And then they fade and fall off between 12 to 24 hours. And so key in somebody coming in that's bleeding on one of these DOACs is when did you take it? And if it's first thing in the morning and it's night, that's good, right? And if you're seeing them first thing in the morning and they haven't taken it since last night, that's good. If they take it in the morning and they cut themselves on their bagel that morning, that's bad, right? Because it peaks very quickly. And you can't use an INR to figure it out for the factor Xa inhibitors to see how they're doing. All right, so the maximum effect, yeah, that's the 3 hours after ingestion and things like that. This gets into the normalization, and that gets to the dabigatran. The drug used for dabigatran reversal is called idarucizumab. And because that drug is very expensive and didn't have we don't know if it had a patient-oriented outcome, my P&T committee came back to our hospital and said, I doubled darucizumab to use that. Right? You better have a good indication. There's going to be a whole bunch of click boxes before that drug's released. All right? They do now, and this slide hasn't been updated, and it doesn't matter because the exam doesn't get updated that quickly, but Adexonate A is now the reversal for your 10As. And again, they did not have a comparison group. They just did, here's what we get, here's the people that are bleeding, and we gave this drug to them. Something like it costs $25,000 per dose, and you need 2 doses for Adexonate A to do it. And we don't know if it's better, worse, or the same as giving them fresh frozen plasma and factors and things like that. All right, that's enough for that stuff. We're going to move on to some disease states. Sickle cell. I'm sure there's some people in this audience who are much better at this than I am with regards to sickle cells. We don't have a lot of people in our community with this condition. Genetically based, chromosome number 11. They tend to run low on the hemoglobin side, high on the retic count side, and they get a big spleen. There's a bunch of other things that go wrong too. So here's the genetic inheritance, and you can see you've got to have both copies, both defective copies of chromosome 11, not defective, but sickle cell copies to be expressing the condition, or you can be a carrier or you don't have it. And they get into a lot of trouble. The vaso-occlusive crisis is the big one, and the sickled cells sludge, increase viscosity, and you end up getting infarcts. And those vascular beds that get infarcted are usually the big muscle beds, so the arms, the legs, the back, the buttocks. The lungs also infarct, and also the brain. Things of stress can cause this, so if they're stressed out in some way, and it can be environmental stress, and it can be cold. Maybe that's why there's not a lot north of the 49th. We don't have a lot where I am in Ontario because we don't have a lot of people with sickle cell traits and diseases. This is the key slide, though, I think. All the different things that it can cause, the bottom line is that it cuts lifespan in half. People only live to their 40s with this condition often, and so it's terrible. So the acute chest syndrome, this is the leading cause of death. So if they ask you, what's the leading cause of death for a sickle cell patient? You'll say that the leading cause of death of a sickler is acute chest syndrome. Now, they're usually hospitalized for something else, and then they get the chest pain and the chest crisis a few days into their hospitalization because pain is the usual admitting diagnosis, and pain is the number one presentation to the emergency department. When they present, they'll be fevered, have chest pain, difficulty breathing, tachypnic, coughing. And most of them are due to infections, but they can also be due to infarctions, embolism, or a combination of all of those things. And it can be difficult to tell based on just a chest x-ray. So if they're hypoxic, we give them supplemental oxygen. We give them supportive care, antibiotics, mechanical ventilation. If they're not even wheezy, we'll consider trying bronchodilators in those patients. Pain management. This is a painful condition, of course. Then these are the other crises you can get besides the chest. You can get CNS, so they can stroke out. This would be painless. They can get into renal failure, acute tubular failure, flank pain, hand-foot syndrome. So this can be the first presentation in the first couple of years of life to go, hey, they might be suffering from sickle cell, and priapism. So some of the problems with it, you can get splenic sequestration. This is number 2. So acute chest, so pain is the first thing, the most common reason for presentation, most common reason for admission, but most common cause of death is acute chest syndrome. Second most common cause of death is problems with the spleen and infarcting your spleen. They can also go into an aplastic crisis. You can see them pushing out, retic count, high, trying to keep that hemoglobin up, and finally it fails. And then infection can be a big cause of death, and again, acute chest syndrome. So of course we're emphasizing vaccination, especially against the encapsulated organisms. There's also, one of the things, salmonella can cause a bone infection and cause that aplastic anemia to happen. Salmonella in this patient population. And so there's the overall approach to hydrate them, give them adequate pain control, supplemental oxygen, transfusion if indicated, and then exchange transfusions if necessary, and antibiotics if indicated. And it's good stewardship to provide them with antibiotics, a low threshold. All right, that's sickle cell. Now we're into hemophilia. So hemophilia, just a few pictures to show you that it can give you a hemarthrosis, extensive bruising, and then mucosal bleeding. There's 2 main types, right? Hemophilia A, 80 to 90% are hemophilia A, and that's factor 8. And hemophilia B, that's factor 9, and that's 10 to 15% of patients. Anybody know? Don't shout it out. I know how competitive you guys can be. Does anybody know what we call factor 9 hemophilia or hemophilia B? I hear you whispering. If you know, find me after the lecture or during the break. I will give you a prize if you can tell me who it was named after. Oh, see, you guys are so competitive, it's like blurted out. Jeez. All right, and they can bleed almost anywhere. Mucosal bleeding, that's why I showed you the pictures. They can bleed into their brains, into their kidneys, bone cysts. The high incidence of HIV has decreased significantly. It's not gone completely, but it's really changed significantly. And so you're looking for, if it's factor 8 and factor 9, which side is it on? It's on the blue side, the blue-colored side. It's part of the intrinsic pathway, right? Intrinsic pathway, so that means we're going to follow PTT. So have a low threshold in treating these people with hemophilia A with DDAVP. It's an antidiuretic hormone. And this desmopressin, or ADH, or I want to call it ADHD, ADH, Floridian slip, it can actually double to triple their levels very, very quickly. It releases von Willebrand's factor, and von Willebrand's factor carries factor 8, and so you can replenish their factor 8. Usually the hemophiliacs I've seen have come in, usually have their own kit and their own dosages and tell me. I'm like, oh, okay, that sounds good. You can use the recombinant factors. They're much more expensive, and we're not usually using the plasma-derived factors anymore. Von Willebrand's disorder, it's the most common inherited coagulation disorder, about 1%, so there's 3 or 4 people in this room probably with it. The bleeding time, the PTT is usually the abnormal one, and the PT is normal. Desmopressin boosts up von Willebrand's factor. It dumps it from your storage, and so you address it that way by giving desmopressin. All right, we're going to finish off with HIV-related emergencies. Again, just like in the sickle cell part, there's probably people in this room that have a great deal of expertise on HIV. This is not going to be meeting their standard. This is the standard to pass the test, to get enough answers to pass the test. The big ticket items that we think have identified, not the nuances of HIV. And so there's 5 main categories of HIV drugs, and they're listed there, from protease inhibitors to nucleoside and nucleotide reverse transcription inhibitors. Then there's the non-nuclear ones, and the entry inhibitors, and the integrase inhibitors. And again, to go back to not Netflix, but a podcast, traveling down to this, has anybody been listening to Malcolm Gladwell's Revisionist History? Because in this season, I think the second last one I just listened to was all about this retroviral club back in the mid-century, last century, and how they were sort of like just shunned and just, you guys are idiots. There's no way a virus can cause these types of cancers and these other types of infections that they were seeing, and these people persisted, and one of them ended up getting the Nobel Prize, right, for identifying retroviruses causing these problems, and in particular HIV. So it was a pretty incredible. So if you want to do something and go, hey, I've been studying full on for this thing for the last 4 days, and you're like, you know what? I'm going to take 40 minutes off, I'm going to listen to a podcast, but I'm going to count it in the I was studying time. Malcolm Gladwell, Revisionist History, that episode was great. The pills that the people are given for HIV are usually a combination. They're poly pills containing different categories of these medications to address the problem in a multifocal approach. We do get approached quite often by either our colleagues or by our nursing staff or someone else in the hospital for post-exposure prophylactic treatment. Depending on the size of your hospital and whether occupational health does this, you might be approached. And so what's the risk of getting it, and how do you treat it? The risk goes up as the viral load of the donor or the person who's had the blood, and then the recipient, to how big it was. It a large cord instrument? Was it just a suture needle? Did they spit at me? Did they bite me? Stuff like that. I still remember the first time I fainted was in residency, of course. First month of residency in emergency medicine, and we were running a code. This was mid-90s. And we were running a code on this young man who was out jogging. It was July. It was a very hot day. He was obviously quite a fit man in his 30s. Like I said, had small little shorts on because he was running, and he collapsed. And this is in the height of the O.J. Simpson trial and the AIDS scare and stuff like that. So they're doing CPR on this runner. And I'm the most junior person, so I'm put down to do a femoral stab. So I get this large cord instrument, and I'm feeling for that CPR effectiveness and for that pulse, and I'm landmarking, and I'm waiting for my opportunity. And they stop to do a pulse check or something at that point, and I go, aha, I have a quiet moment, and I go, and I get a flashback, and I'm like, oh, I'm so good. I'm going to ace this residency. I'm the best. Right? You ever had that moment where you're like, oh, and then it all comes crashing down. They start CPR again. He's a thin, fit, athletic man. The pelvis goes up, the needle comes out, and funk. I impaled myself through my hand with like a 16. And I'm going, I don't feel very well. Could I get a ginger ale and a turkey sandwich? I think I'm going to sit down. Is there a bed? Yeah, some nurses took care of me. But like this was a big deal back then because we really didn't know everything that was going on. And the bigger the cord instrument and the more viral load in the blood that you get, the more likely you are to get into trouble. And so they talk about 3 in 1,000 or 30 out of 10,000 exposures, but it really depends, right, on the viral load and the type of exposure you're talking about. And then they've got a combination of usually 3 different types of pills. You should start them as soon as possible, within 72 hours, but as soon as possible. And the other thing is you have to take it for a month. And the most common reason people stop taking it is because of GI upset. It upsets their stomach and they don't complete the course. But this can prevent, post-exposure prophylaxis can prevent seroconversion. The drugs I listed there, sometimes they change. You know, the recommendations come out and changed. I just grabbed this off my hospital stuff. The one there is if they're pregnant or not. That's why it's one or the other. All right, some other HIV-related emergencies. You can get lactic acidosis, very deadly. Up to 60% of people who get lactic acidosis as a part of their medication regimen with their antiviral drugs can die from this, so it's pretty intense. And obviously it's giving them sodium bicarb as a mainstay of treatment, but the mortality rate is really high. And it just reminds us that, you know, when I was listening to that podcast and all the scare, and it was a death sentence back in 1995 practically. I had just been married. All the, you know, catastrophic thinking goes through your head, right? And now, while it isn't a death sentence and it's a chronic condition, there's still really significant burden to this, a lot of morbidity to this, and lactic acidosis is one of those conditions. Immune reconstitution syndrome is another one, where you ramp up the immune system again, and then your body responds to some latent infections like TB that have been sitting there, and all of a sudden, whoa, an overwhelming immune response to that latent TB that's been sitting there if you get this reconstitution symptom. And so now you have someone with immune deficiency that you've jacked up their immune system that you have to tamp back down with steroids. So you can imagine that that can be quite difficult. Other medication-related problems, certainly hypersensitivity reactions, but you can get kidney stones with this, Stevens-Johnson syndrome with these medications as well. So while they have radically changed our approach to HIV and improved the life of many people, it's still got a number of side effects. Now let's go through just a few final things on specific HIV-related emergencies. So one of them that I think that would be completely reasonable to ask you is either show you a picture like this up in the top right-hand corner and tell you a story about somebody's, you know, T-cell count is below 50 and they're having trouble with floaters or spots in their eye or some kind of visual acuity problem. And you're supposed to recognize, okay, yeah, it's a two-parter. Yeah, I realize that they have HIV, but they say, what's the most likely diagnosis? It is the most common vision-threatening infection in HIV. And you're going, oh, CMV. I'm with the gang, because I'm going to use gang-cyclovir. And gang-cyclovir is the answer, because they may ask you, you know, put that whole scenario together, and you're like, yeah, I know that's HIV. Yeah, I know it's CMV. Crap, they asked me, acyclovir, gang-cyclovir, valcyclovir, all those. Right? So get with the gang. If they've got CMV, get with the gang. Gang-cyclovir is the treatment for that. Now, zoster is different, though. Zoster, it's acyclovir. And you know that herpes zoster ophthalmicus, that they get that, you know, that nasociliary branch, right? And it drops down to the tip of their nose, and they get Hutchinson's sign. And they got that blister right there. That means they could have corneal involvement. You can also get retinal involvement and retinitis. That's acyclovir for those individuals. Gang-cyclovir is for the CMV. And the CMV is the most common vision-threatening. Zoster's second. All right, pulmonary emergencies. Well, you know, PJP, it used to be called PCP, but now it's pneumocystis jirovecii pneumonia. PJP, they change the names from time to time. But PJP is exactly what PCP was. They just flipped the name. It's the leading AIDS-defining diagnosis in the United States, and you see it with the T cells drop less than 200. All right, they get a fever, they get a dry cough. The real tip-off usually is the fatigue is out of proportion. They don't, like, you know, like the chest x-ray doesn't look that impressive. Their SATs aren't that low. They're not running a really high fever, but the fatigue is the profound part of getting PJP. The chest x-ray, sputum exam are the way you make the diagnosis, and they get trimethoprim, sulfamethoxazole, and steroids, and that improves the situation. And then the rest of the bacterial pneumonias, treat them as you would anyone else. And there's a nice picture of PJP for you. I don't know why they changed the name. I'm sure there was some good reason. Maybe we all got to learning to say PCP or spelling it properly, so they said, yep, it's time for a change. All right, HIV-related emergencies when it comes to the CNS. So CNS-related emergencies involve cerebral toxoplasmosis. This is what you get when the kitty litter and stuff, or uncooked lamb, uncooked pork. That's where the toxoplasmosis lives. You usually see it in T cells less than 50 again, so the immune system can't fight it off. And they come in and they're a little off, they've got a little confusion, a little altered mental status, maybe a low-grade fever. Up to 50% of them can seize, though, and stroke. So the diagnosis is you get a CT and you see this ring-enhancing lesion on the CT, and so it's usually quite obvious. And you can get IgG antibodies to toxoplasmosis to make the diagnosis. And then cryptococcal meningitis. This is the most common systemic HIV fungal infection. And you're usually doing the tap and looking for the fungus and doing the appropriate staining and culturing for that. The meningitis is usually less severe in the presentation. It's milder, it's more insidious in onset and stuff like that, and it can be more difficult to diagnose. And there's the ring-enhancing lesions that you get with toxoplasmosis. It's like, whoa, okay. Like you may be pretty good at reading CTs, but I don't think you need a lot of expertise to go, that ain't normal when you see something like that on the CT scan. You're not looking for some small little bleed or something like that, or a lacunar infarct. It's like, there's 2 rings in that one shot. It's pretty easy. All right, finishing off with HIV-related emergencies that involve the GI tract. The thing with the GI tract and HIV is it can be the HIV, it can be an opportunistic infection, or it could be a side effect of the medication, or a combination of all of those things. And it can affect you anywhere from the oral mucosa down to the rectum. And so from top to bottom and the 30 feet in between could get impacted. And in fact, this is the most common reason people with HIV come to the emergency department is because of some GI-related problem. And so diarrhea and abdominal pain related to infection or non-infectious things. Opportunistic infections. Again, if that T cell drops below 200, that's when people start getting into trouble, and then they get below 50, they get into a lot of trouble. The oral pharyngeal, the usual stuff like, strep throat, but a lot of thrush as well. Into the intestines, you get Salmonella, Shigella, C. difficile, Campylobacter, and down into anorectal, we can't forget about sexually transmitted infections, gonorrhea and chlamydia, and we're seeing this insurgence of syphilis. And then hepatobiliary and pancreatitis can be involved in there as well. And then some viruses down at the bottom. And there we go. Thank you very much. That's my first one. I'll be back shortly.